Well, welcome back everybody to the CMT United Kingdom conference. This is our final session. This is the research session, and we have joining us Debbie Delves, who is a trustee and chair of the research committee, Matt Welk and Karan Malhotra, who will be talking to us later about a research project they're working on. So I shall go straight to Debbie and ask her to tell us all about the research board, research committee. Thank you.
Thank you, Simon. Right, let me share my screen. Bear with me. Okay, there we go. So, hello everyone, good afternoon. The research committee was set up as part of a wider governance review of the way CMT UK works. We've created a number of committees to allocate tasks between trustees and to ensure a more efficient use of our time when we meet. We've had a number of valuable donations from our members, and these have been ring-fenced within the charity for research, and the trustees decided that we needed a more organised and formalised process for the use of these funds. So the committee consists of 3 trustees. There's myself, I'm a podiatrist by profession, and then we have Karen Rogers, who many of you know. Karen has been involved with the charity for over 20 years, and as you know, she's been involved, or she works tirelessly with CMT Kids. And then we've got Alan MacDonald, who's a relatively new trustee, and he's a medical trainee by profession. So what does the research committee do? We're here for a number of reasons. Our first reason is to drive the execution of the charity's research objective, or one of the charity's research objectives, which is to initiate, coordinate, promote and support research into CMT and its effects. The second thing we do is to formulate the charity's research strategy for the Board of Trustees to review, and we'll look at the research strategy in more detail in a moment. We give recommendations to the Board of Trustees around spending of resources for things like research grants and the school award, and again we'll talk about those in a little more detail shortly. And we approve the composition of the Scientific Review Board. Now, the Scientific Review Board is a group of medical experts with a special interest in CMT, and they advise the Research Committee on research matters, and the Scientific Review Board is chaired by our patron, Mary Riley, who you heard from this morning. We work with other charities and research organisations, including the Inherited Neuropathy Consortium, and sitting on groups like the INC enables us to keep abreast of international research initiatives and to get involved directly where appropriate. So our research strategy focuses on initiating, coordinating, promoting and supporting research into CMT, as we said earlier, and its effects, into CMT and its effects, while supporting the overall objectives of the charity. So we're wanting to improve the lives of people with CMT, and we're using a pragmatic approach for the utilisation of our funds, and we want to maximise our resources for the maximum potential benefit to our members. So just give me a moment. So our research priorities are to focus on UK-based research, and we want to be looking at projects that satisfy one of 2 objectives. So we want them to either show immediate benefit to the patients or have an anticipated benefit that will be seen within 5 years of study completion. So we want something that's going to show its results very quickly, or something that will stimulate further research, so pilot studies. And as far as the sort of subjects that we're prepared to consider. As long as it's CMT related, we're happy to consider that, anything really. So what's going to happen is in September, we are going to put a call out for grant applications, and those applications will be reviewed by the Scientific Review Board, which consists of a panel of professional experts, so people like neurologists, paediatric neurologists, orthopaedic surgeons, and they will make recommendations via the research committee to the Board of Trustees, who of course are ultimately responsible for deciding how we spend CMT UK funds. So this year we've awarded a grant of £11,700 to Matt Velk and his team at the National Orthopaedic NHS Trust, and we're going to be hearing from Matt and his colleague Karen in a few minutes. Their work is on the use of artificial intelligence in defining forefoot deformity in complex pes cavarius feet in Charcot-Marie-Tooth disease, and using that artificial intelligence to predict surgical outcomes. And as a podiatrist, it's really exciting work. Our other big initiative this year is the launch of the School Award. Now, we talked to you about this when we were last able to be all together in the room in 2019, and then sadly, because of COVID, the launch was postponed, the schools closed, and really everyone was trying to focus on the essential stuff as far as schooling the children was concerned. So we delayed it, but we have launched it this year, and so we sent that out in January. The main aim of the School Award is to raise awareness of CMT and to engage the next generation of potential researchers. And the details have been sent to schools and sixth form colleges nationally. The award is for 16 to 18-year-olds, and you can also find details on our social media and our website. The first prize is £500, and there are 3 runner-up prizes of £250 each. And the essay topic is really open and can cover any area of living with CMT, from its socio-economic impact to ideas of technology to help people with living with CMT. The essay needs to show its practical or research or social impact on people with CMT, excuse me, and we've got a closing date of the 30th of June. And we'll be announcing the winners to you in September, and hopefully if we're all live next year for this conference, then there'll be a presentation at next year's conference. And really that's it. That's what we've been up to. That's a summary of our work for the last year, our early plans for the upcoming year. And before we hand over to Matt, are there any questions?
I'm just having a look to see what we've got coming in. Anyone got any questions for our research committee? Doesn't look like it.
Fabulous. So, am I still sharing my screen?
No, you're fine now.
Okay, great. That's wonderful. Well, in that case, I would like to hand over to Matt Velk and Karen Malhotra. Matt and Karen are both consultant orthopaedic surgeons consultant orthopaedic foot and ankle surgeons at the Royal National Orthopaedic Hospital.
So, thank you, Debbie. Hi, everyone. So my name is Karan Malhotra, and I'm a consultant orthopedic foot and ankle surgeon at the Royal National Orthopaedic Hospital. I'm here with my colleague, Mr. Matt Welk, who's also a consultant surgeon with me. And thank you very much to CMT UK, firstly for the grant and also for having us here to speak to you all, to give us really the opportunity to tell you a little bit about the exciting work we're doing and plan to do. I'm also an honorary clinical lecturer with the Department of Orthopedics and Musculoskeletal Sciences at University College London. So this talk is going to be a bit of a split talk between Matt Welk and myself, and I'm really going to lay the groundwork about it. And as part of that, I just wanted to give you all listeners an idea about who we are, so that we can tell you why we've been awarded the grant, as it were. So the Royal National Orthopaedic Hospital is what's known as a tertiary referral center for musculoskeletal conditions. And that means that we get patients from all over the country. We even get patients internationally. And it's because we're very specialized in certain areas. In fact, the Royal National Orthopaedic Hospital this year was voted by Newsweek as the ninth best orthopedic hospital in the world and the best in the UK by far. So we're one of the only ones in the top 50. So that is partly because of the expertise that we can deliver, but also because we're continually striving to develop the care that we offer through research and innovation. Our unit specifically consists of 4 consultants, and the 4 consultants are pictured here. So on the bottom left is Nick Cullen, who's our head of our unit, and then there's Matt Welk, who's our research lead, and then Shilin Patel, and then myself. And we all are involved in research. Beyond that, we have a special interest in complex deformity and neuromuscular conditions, of which CMT is one. A little bit more about the unit. So patients with CMT-related foot and ankle problems are from across the UK to see us, and we see the largest number of CMT patients in the UK, if not in Europe. And last year we saw 80 new patients with CMT, and some years we'll see more than that. Of course, we have a large cohort of patients who we've been seeing for a number of years, following them up, and we coordinate their care with the specialists in the National Hospital for Neurology and Neurosurgery at Queen Square. And I believe you've heard from Professor Riley earlier today. Now, the interest in the neuromuscular service was set up by one of our predecessors, Dishan Singh, who's pictured here. And many of you may know him. He may have, in fact, treated some of you. But he's now retired, and I was fortunate enough to take over his practice. And he's recently published on the largest series in the world on surgical management of patients with CMT. So a disclosure, as we've said before, we have received a grant from CMTUK in April this year for £11,700 to carry out research into the Caboverus feet, particularly in CMT. And more details will follow in Mr. Welk's talk. But again, as I'm going to show you now, I'm really setting the scene for it. So why is this research important to us, and why should this research be important to you? Well, I can't work out really from the attendees list, but at least some of you have CMT. Well, a survey done by CMT UK itself has shown that about 3/4 of patients with CMT have an impact. It impacts on their ability to work. And about 2/3 and over a half have restrictions due to the CMT, which makes finding work difficult or means they have to retire early. About 1/4 of people who start off with CMT end up having to change their career on account of it. CMT, as I'm sure you know, was described first in the 1880s, and the feet are involved in the vast majority of patients. So 70 to 90% of patients have some involvement in the feet. And the typical picture we get is something called a Caboverus foot, which is something I'm going to describe in the next few slides. It's a group of disorders which affects the nerves. And in fact, it's the most common genetic disorder affecting the peripheral nerves. And it's estimated that about 1 in 2,500 people will have it. And really, as I'm sure you all know, the hallmarks are loss of sensation and loss of muscle strength. And that causes issues with balance, it causes issues with gait, it causes issues with foot abnormalities. But the key thing here is that the degree of disability people may have is variable. And some people may present with relatively mild disease and need to be treated one way, and some people present with severe disease, which needs to be treated a completely different way. Now, what is the Caboverus foot I've been talking about? Well, the main thing is that it's a complex deformity and it's a 3-dimensional deformity. And that's important because in the past, we've used X-rays to look at these things, and X-rays are 2-dimensional shadows, if you were, of what the foot really looks like. And the key features are you have a high arch, you have a twisted heel, so the heel twists inwards, you have a twisted foot, and that's partly bent, so the foot can be bent in one way and the foot can be rotated one way or another. And you have clawing of the toes, so the toes all bend upwards and can rub on the shoes and dig into the floor and cause problems. And that's a typical picture of someone who I would say has perhaps a moderate foot deformity. And you can see here there's a high arch. If you can see my pointer on my screen moving about, I'm not sure if you can, but there's a high arch on the inside. There's a toes which are clawed up. There are toes which are all over the place. And you can see the heel is going one way or another. But why does this happen? Well, as we said, it's a disorder which affects nerves, and what nerves do is they supply muscles. And when the nerves to a particular muscle become weak, then that muscle becomes weak. But the key thing is that some muscles get affected more than others for reasons we still don't really fully understand. And that means that there's an imbalance. And so the foot is something that you can envisage it like a tug of war, or you can envisage it like putting up a sail on a boat. It needs to have the right tension on either side to keep that sail afloat and keep the inflated with the wind and let it go the way you want it to. And if you have only one muscle working on one side and you have lots of muscles working on the other, that balance is going to be tipped, and that pulls the foot one way or another. The next thing you need to understand is that the foot is like a tripod or a three-legged stool. And although we think of the foot as a flat surface which pushes down, it really has three main contact points, and that's on your heel, your big toe, and your little toe. And the rest of the foot, as if you will, fills up the gap. And if you were to take a tripod or a three-legged stool and you were to lengthen one of the stool legs, you'd get a situation where all the load goes on one side, and you'd end up with a wobbly tripod or a wobbly stool. And that's no good. And if you went the other way, then again, you'd wind up with a wobbly stool the other way. So really what you need is some way to balance things out. And so your foot naturally tries to find a place where 3 points are touching, even if that means the whole foot has to wobble to do so. And the next key thing to understand is that some deformities are opposite. And the foot in CMT has been likened to wringing a towel. And that's because the heel goes one way. For example, the heel may go inwards, and that will tip the tripod over. And therefore, the big toe needs to come down to touch the ground. There's also a school of thought that actually it's the big toe which has the problem first, in which case the big toe goes down and it's like having a long leg on a stool, and that tips the rest of the foot over. The reality is you probably have a bit of both going on, because you have a bit of muscles pulling the inside of the foot, the back of the foot inwards, and you have muscles pulling the front of the foot down, and that creates a very misshapen foot. But the key thing is that those deformities are opposite, because they're balancing each other out, or at least trying to. So what problems does this cause? So here's a video of a patient of ours who has CMT, which you're using with his permission. So you'll see here as he's walking, he's slightly uneven. And you can see the heel is pointing inwards, the foot's pointing inwards, and the toes are going up in the air. As he's walking, you see he loses his balance because that's not a very stable tripod. And again, he's walking again. If you pay attention to the different parts of his feet, you'll see his toes are curled, his toes are going up in the air, and he really doesn't look steady at all. So what do we want to achieve? Well, we really want to achieve correction of the deformity. And the reason to achieve the correction of deformity is to improve balance and improve walking. And the way we try and do that is we try and create a flatter foot, and we try and untwist the foot so that it looks like a normal foot. So here's the same patient after he's had both sides operated. So you see here as he's walking, he's a lot more stable. The foot's a lot more flat. He doesn't fall over when he's walking. His toes aren't going up. I don't know if you can hear what he's saying, but he's saying it feels very strange because probably for the first time in his life, that's the way he's able to walk. So how do we achieve that? Well, it's a combination of things. So firstly, we realign the bones. And that's because over time, by the time we see patients and by the time patients are bad enough for surgery, their bony deformities are fixed. And so if you imagine my analogy of the three-legged stool again, with one stool which is wonky, as it were, or long, to balance it out, you'd need to shorten that stool leg which is long, or lengthen the other ones, or get them lined up in some way. And so that means that often we need to break a bone and reset it, and that may be the heel bone, that may be the toes. And then we need to balance the pull of the muscles, because if you go back to the analogy I used of the sail, if you have too many people pulling on one side of the sail or too many muscles on the other, then even if we balance the bones, it's still going to pull over. And so what we do is we unplug a muscle from one side where it's too strong and plug it into the side where it's weak. So we kind of have equal number of muscles, or at least equal strength, working on either side. And that balances things out. But if you remember a few slides ago, I said that everyone is different. Some people come with relatively mild disease, some people with severe disease. And so actually what's important as a surgeon is that we offer every patient something slightly different, which is bespoke and what's required for them. But in order to do that, it's really crucial that we understand the deformity that that individual patient has come with so that we can tailor our surgery to meet their specific needs. So how do we understand this deformity? Well, of course, we examine the patients and we see how flexible things are. We see where the deformity looks like it is, and we see how strong the muscles are. And then we use our experience. And as we said in Stanmore, we actually have over 20 years of experience, over 4 consultants looking at these. And then we look at the X-rays or the CT scans to look and see where are the deformities and how we may best correct them for that patient. And that works for most people, but it doesn't work always. So when might this not work? Well, it may not work if you've got a very severe deformity which may be fixed. So if you see here, this is a 3D reconstruction of his weight-bearing CT scan. And you can see that when the patient's standing here, one side's not too bad at all, but the other side, he can't get his big toe to the ground. And so what you have here is, yes, you have a hindfoot deformity, which is your heel deformed, but the forefoot, which is the front of the foot, is really twisted and deformed. And this foot is not only out to the side and up in the air, but it's also twisted across and there's a very tight tendon. And this particular patient, when I examined him, I couldn't really work out how far I was going to be able to correct things and what the foot would look like when you release the tendons. And so you come to a situation where you're slightly stuck. And you're slightly stuck because you're thinking, well, when I go and operate on this patient, when I release the tendons and make the bones, what am I going to be left with? And am I going to be just left with deformity? Am I going to be left with rotation? What am I going to do next? And often these patients will be young patients. And you got to think, well, I could then be left with something where I would do a big, take away a lot of bone and correct it this way, but that would really remove some of his joints. And how is that going to affect him in years to come? And if there was some way that I could work out how to address this forefoot deformity, maybe with the help of a computer, then maybe I could plan that a bit better and decide what to do ahead of time, spare some joints, and give an operation which is more tailored to that person. But we can't do that yet, and that's the problem. So in summary, foot and ankle deformity in Charcot-Marie-Tooth is common, but may be complex. And understanding the deformity is the key to effective treatment, and really us not having to guess on what we're going to find in the operation and being able to plan things properly. But that's not always possible. So at this point, I'd like to hand over to my colleague, Mr. Welk, to address the research that we have planned to try and help us answer these questions and improve the care of foot and ankle conditions in Charcot-Marie-Tooth. So thank you very much for my attention. And Matt, do you want to continue?
That's great. Thank you very much, Karan. That was fantastic talk. I'm just going to share my screen. Karan, that was brilliant. Thank you very much. And I'm Matthew Ark. I'm another one of the consultants in the foot and ankle unit at Stanmore. And as Karan said, we treat a huge number of CMT patients. In fact, certainly the most in this country and probably one of the most in Europe. And if you advance the slide, Karan. So the first thing is a thank you. So this is a letter we're extremely grateful for, saying that we were successful in the grant of £11,700 from CMTUK, and that was after I presented this concept to the research committee of CMTUK. So we were extremely grateful, and the purpose of this next 20 minutes is to tell you what we intend to do with the money and where we're up to so far. So I'm going to start off by talking about something which is not strictly relevant to CMT, but is relevant to the whole concept of what we're doing. And the two main foot deformities, the commonest foot deformities that we see, the foot shapes, will be a flat foot and a high arch foot, so the two extremes. And if you look at the opposite, so the CMT patients, as Mr. Malhotra was saying, tend to get the high arch foot due to the muscle imbalance. If you look at the other extreme, which is the flat foot, the foot and ankle community is a massive way further forward in terms of the flat foot. If you just go back one slide, Karen, sorry. And with the flat foot, there is a really good classification system. And a classification system is only really useful if it helps guide your treatment. So there's no point classifying a condition if you can put it into different categories, but it doesn't really help you treat that patient. So a classification system is useful if it helps you to plan the treatment. And what's been happening in the world of the flat foot is that over the last sort of 15 years, and especially in the last sort of 2 or 3 years, due to an increased understanding of the deformity of the flat foot, especially using the weight-bearing CT scanner, the classification is evolving. So on the bottom of this slide here is a paper from 2020 in Foot and Ankle International, which basically says we're going to rename the flat foot into something called a progressive collapsing foot deformity, and let's have a whole new classification for it based on information that we found out from knowing more about the flat foot. So if you go on, Karen. So we start off with, I'm not going to go into any detail on this slide at all, but this is the first classification of the flat foot, which basically was stage 1, which is mild, no real deformity. Stage 2, which is a flexible deformity, and stage 3, which is a fixed deformity. And if you look down the left-hand column, you can see that it describes what you'd expect to see in each of those different stages, but at the bottom row, it has treatment. So that's really simplistic, and it's a very useful classification system. And if you can classify your flat foot into either mild, flexible, or fixed, and this is how we suggest you treat it. But it then went on a bit later to exactly the same. Look on the left-hand column, stage 1, 2, 3. An extra stage was added in stage 4, but within each different stage, a huge number of extra stages were added in, a huge number of extra characteristics. And again, if you look, you've got the first column is, this is the stage. The second column is, this is what it looks like. And the third column is, this is the treatment that we suggest. So the flat foot has progressed into different stages, and this is how you treat all different stages. And then the next slide will then show this recent thing, which is we've now used, or their group have now used, the weight-bearing CT scanner, which is a way of getting a CT, a 3-dimensional image, much better than the 2-dimensional images we were talking about before. And essentially what it has is class A, B, C, D, and E, which is these are different components of the flat foot deformity. And the next bit is what you find with it. So it's essentially breaking up into different components of the deformity. And now there's research going on in the world of the flat foot, which is how do we treat all different parts of the deformity and how does it affect things? So if we now bring ourselves back, so if you go forward a slide, onto the cavus foot, so the Charcot-Marie-Tooth cavus foot. Now, the first thing to mention is that it is more complex than the flat foot. And I think nearly all foot and ankle surgeons would agree, and that's why it only really tends to be treated in specialist centres. And the reason why it's more complex is that there's a lot more rotational deformities. So you have deformities in multiple different planes, deformities in the planes moving up and down, side to side, but also there's lots of twists in the foot. And as Mr. Malhotra was mentioning, different parts of the foot are twisted, and it makes it difficult to treat. So it's more complex. And we don't have a classification system at all for the cavus foot, really. Where we are at the moment is before even the first classification that we had for the flat foot. So we have a flexible cavus foot we treat in a certain way with a certain mixture of operations, and a fixed cavus foot you treat in another way, and that's basically it. And the individualized treatment that we offer is based on experience and based on how you examine the patient. But we don't really have a decent classification system that might help people who don't treat the foot quite as often to be able to know that if you have this characteristic, we would suggest that you do this. So we are a long way behind in the cavus foot than we are with the flat foot. If you move on to, I'm not sure if you'll be able to play this video, but this is, I'm saying it's vital. This is a patient of mine with CMT, and you can see here, similar to Mr. Hotra's video, he's got an extremely wasted leg, he's got a high stepping gait, and you can see the cavus foot deformity, and you can see he's got a foot drop as well. This is a very typical, and this patient was 16 and sadly was having a difficult time at school, and he really needed to have something done to give him a better gait pattern and a good tripod. And it's vital to get these operations right, to allow these patients to get functioning and to be able to have a better quality of life. This is what, when you do get it right. So the left-hand video, this is courtesy of one of my colleagues at Stanmore. This is, again, a patient with CMT before the operation. It's a bit laggy, but you'll see the very unsteady gait, difficulty balancing on the tripod. And the next video is post-operative, a few months post-operative. And I wish you could hear her laughing when she's doing it, but the difference in her and her balance, the way that she's walking, the way that her foot progresses is so much better. So we can make a huge difference to patients' lives. And the first step is to understand the deformity, and it is a very complex deformity. You can see this is a patient here. You obviously won't be able to see my arrow, but with a severe cave of varus foot. And if you look at the scan, you can sort of notice that if you look at the ankle joint is pointing one direction. So the ankle joint, if you imagine that bit moving up and down, is pointing outwards, and the whole foot then twists inwards, and also what we call supinates, where it's not only curved inwards, but it's completely twisted. And there are deformities here in the ankle. There's a deformity in the back part of the foot or the heel. There's a deformity in the middle part of the foot or the midfoot, and there's deformity in the front part of the foot. So this is a complex, multiplanar deformity. And with existing methods of trying to look at this deformity and trying to evaluate it on X-rays and CT scans, it is very difficult because this is very much a three-dimensional deformity. So if you look at a two-dimensional slice from a CT scan, so if I take a CT scan and I get one slice in whatever plane this might be, it is very difficult to interpret that because the whole problem is three-dimensional and rotational. So if you move on to the next slide, Karen. So this moves us on to the grant that we've applied for. And the premise behind it is we want to understand the complexity of the rotation and the three-dimensional complexity of the cave of varus foot secondary to CMT better. And we had a meeting a while back with a company from Finland called Disior. And what they essentially do is three-dimensional imaging of the bones and also three-dimensional working out of the axes of the bones. So very simply, we get a CT scan and we upload it to this program, and the grant has gone towards two things. Firstly, it's the program itself, so the software, and secondly, it is the computer, which has to be a very high specification computer that runs the software. And actually, although the grant was received in April, anyone who works in the NHS will realise that the NHS procurement doesn't move very fast and has to go through a million hoops of red tape. And sadly, I'm actually proud to say that our computer with the Disior software is arriving in our office next week, and that is very fast moving compared to how most things move in procurement. So what you do is essentially, if you go back one, Karen, sorry, you upload your image, and then you tick on all these things. So, these are the bones that I'm going to select. So we would select all of these bones. We want to look at the whole foot. Then you move to the next slide. You then mark. So you mark each bone. So all we have to do is mark the tibia, the fibula, the talus, the cuboid, and the vicula. Put a mark on each bone. You'll see here, select all the bones to be included in the analysis. So we could look at a specific part of the foot, the ankle, or the hind foot, or the midfoot, or all of it. And you select the bones. You move forward one, Karen. And then when all the bones have been selected, you run Analyzer. So you click Run Analyzer to carry out the analysis and select left or right. So it then automatically, if you go forward one, gives you all these different angles. Yeah, it gives you all the different angles in 3 dimensions, and it works them all out for you automatically. And the beauty of that is, if you go forward a slide, is that if you can imagine, even on if this is a two-dimensional image, so it says 3D view, but imagine this is just one slice, you could quite easily put your red arrows in different angles. So if you're doing this manually, you could quite easily put either of those red arrows slightly up or slightly down, and it's quite difficult to be accurate. Whereas what this software does is it looks at hundreds of thousands, if not millions of points within each bone, and then works out the exact right axis in 3 dimensions of each bone. And that is something that is very difficult to do even on a 2D image like this. But when you've got a complex deformity like CMT, where there's rotation and there's twists, then being able to calculate these 3-dimensional images, 3-dimensional angles, is something which we haven't been able to do before. So we felt when we met Disior, this would be perfect to help us analyze and understand the cave of Erebus foot. So if you then move forward. So this is the main slide, and this is what we intend to do. And our goal, as I said, is to understand the complex deformity of the CMT cavus foot, to be able to evaluate the deformity properly, and to be able to plan the correction as best as we can. So the first step that we need to do, and we'll be starting this next week, is to validate the artificial intelligence axes, so the automatic ones versus the manual ones. And what I'm sure we'll find is that they will be different. And we will then conclude that AI is most likely to be much more accurate than doing it manually for various reasons. So we'll probably find they'll be very different, and we'll be able to show that using the 3-dimensional way of doing it will be much more accurate. And then we move on to the next stage, which is to accurately define the deformity in the Charcot-Marie tooth foot and all the different components. So we're going to look at every single joint, the ankle, the hind foot, the midfoot, the forefoot, and we're going to look at exactly the deformities there are. So how do they move up and down, side to side, and twist? Because we're looking at this in 3 dimensions, we can evaluate the deformity properly. And we're going to evaluate the deformity in the position that it's scanned in, and also in a forefoot corrected position, which I will explain that in a moment, because that's one of the most difficult things that we, even as experienced CMT foot and ankle surgeons, one of the hardest things that we find is managing the forefoot. And this is going to really help us to be able to do that. And I will explain that to you. And then once we've accurately defined the anatomy, we want to be able to translate that to standard techniques, because really we want to be able to help other foot and ankle surgeons and be pragmatic about it. We can't really say everybody has to have this expensive program to be able to treat the CMT foot. So we need to use the research to understand it and then make that translatable into people that don't have this special software, but be able to have a standard CT scan. So we want to be able to compare what we find and translate it onto standard techniques to make it more applicable. And then the next part of the studies, which is going to be, this is really, years worth, probably a year, 2 years worth of studies. We're going to see how the different operations that we do affect the different parts of the deformity. So if we do this operation, let's see, or this cocktail operations, let's see how that did at correcting the deformity, now that we can look at the deformity much better. And once we can do that, we can then start to go back to what I started off with about talking about classification. So we can say, these are the different parts of the deformity that we found, as in the latest classification for the flat foot. And when you have this, we suggest that you do this operation. So you can standardize treatment and we can work out what is best to manage the complex feet. And that is our overall plan. And I would imagine in the whole thing, it will end up being 20 or 30, 20 plus studies on the cavus foot in order to reach our end goal, which will be to have a classification of the CMT foot to help guide management. If you move on one, Karen. So I mentioned I was going to speak about the forefoot, and this was where we really started thinking about this whole thing. This is one of the problems that we have. So if you look at these pictures here, and Mr. Malhotra was talking about it, what we do when we correct the foot is we start at the top and we correct the ankle, then put the hind foot, so put the heel where it wants to be, so from being inwards to outwards. And then we see what the midfoot looks like, see what the forefoot looks like. But it's very, very difficult to predict that. And it's very difficult because if you imagine the foot that's on the right-hand side, that foot, I can tell you from looking at that picture, is rigid. And that foot is not going to correct. Maybe the one on the left-hand side have a bit of flexibility to it, but the one on the right-hand side is going to be fixed in that position. So when you examine the patient, you think, right, when I correct the heel, you have to try and visualize it. Once the heel goes back to a neutral position, what's my forefoot going to look like? Is it going to be twisted downwards? Is it going to be twisted inwards? And so what we end up doing is doing it during the operation. So we'll correct the back part of the foot and then see what the front part of the foot looks like and work out how to fix it from there. And sometimes it's less than optimal because in correcting the back part of the foot, you have done something which might compromise where you can real estate to fix the front part of the foot. So being able to understand the deformity better and to be able to predict the deformity better would make a huge difference to our management of the patient. So if you move on one. And as Ms. Malhotra said, I think we do a fantastic job with all of these patients, and we have a huge majority that are very, very happy, and we almost always improve things. So every patient is better, but if you're being critical and you want to be perfect, we do have some patients who, despite the fact their heel is corrected, they have a little bit of a forefoot deformity after corrections. Maybe the heel is perfect, but the front part of the foot is still twisted in a little bit, and it's not 100%, then way better, but it's not absolutely perfect. So and that's why we're moving on to think about all these studies. If you move on to the next slide. So we did a pilot study. So prior to approaching CMTUK, we said to Dizzy, look, we would love to do some work with you, but I don't want to apply for a grant if it's not going to work, if it's not going to work for this indication. So can we do a pilot study just to see if my concept or our concept is going to work? Because we don't want to apply for money and realize that actually this is a non-starter. So we got 12 patients with CMT, put them into the system. They kindly did it for us free of charge because we said that we again pitched to them and said this could be a whole load of great studies, and they were keen to work with us. So we put in 12 patients with CMT and to measure all these angles here in 3 dimensions. If you move to the next slide, this is obviously not going to read this. These are the 12 patients in columns, and these are all the angles here that they measured. And if you move forward to the next slide, what is really, really interesting, and if you just hang on a minute before you play the videos, Karen, you can see from this foot here that this is a foot where the forefoot and the front part of the foot is twisted inwards and rotated. And the first thing that we can do is measure the angles much more accurately in 3 dimension in that position. So we can get the angles and measure them in that position. Then the other thing that we can now do, which is a total game changer, is this program can simulate correction of the hind foot to where we feel we can get it to and see what the forefoot will look like. So it can do that prediction that we can't do. So if you play the video, you can see here that it's simulating correction of the back part of the foot, and it's seeing what the front part of the foot looks like. And then it's showing us what we need to do to correct each element of the front part of the foot. And if you move to the next slide, it's even more, this is looking from the side, and you can again see that it's 90 degrees twisted. And if you play the video, we can simulate correction of the foot and the hind foot, and you can see that in this particular example, the first ray is more pointing downwards or plantar flex than all the other rays. So using this software, we can simulate prediction of the correction of the hind foot to see what the forefoot will look like, which is really, really powerful. So if you move on to the next slide. So we want, in terms of defining the deformity, we want to see, amongst other questions, is can we use these software, which we will use, to accurately define the forefoot deformity in patients with CMT. So we will be able to say, once we've done these studies, that when the back part of the foot is in this position, and the forefoot is in this position, in the normal scan positions, it means that once we correct the hind foot, the forefoot will be in this position. So we're going to correlate what we find in the normal scan position to what the corrected position will be like. So as I said, when we can look at the scans, and hopefully other people can as well, and say that when you've got a hind foot that looks like this, the heel's in like this by this degrees, and when you've got a forefoot that's twisted in this way, then we know that once you correct it, the forefoot will look like this. So this is all part of us defining the deformity, so we can understand the deformity better by simulating the correction. So if you move forward. So the applications of this are firstly in helping diagnose the patients. We can define the deformity much better. We'll be able to monitor progression of deformity. We'll be able to do this for different CMT genotypes. And we might be able to understand what factors mean that is going to progress quicker. We might need to intervene. And in terms of treatment, we want to use this analysis to help us plan our surgery and then to demonstrate improved outcomes. So the first part of the study is to understand the deformity really well in the scan position. Once you have this, to really depict the deformity, and by being able to simulate correction, we can really understand the deformity better. And the second part of the study is to then work out which bits of the operation correct which bits of the deformity, and then come up with a classification. So if you go to the final slide, Karen, we genuinely feel that this software will revolutionize our understanding and the treatment of the complex foot deformities in CMT. And we feel that it will help us to manage the patients now, because we can do this correction now. So even if we just have this to manage our patients, it would be fantastic. But we're going to use it to do a huge amount of research to be able to really bring the cavus and the CMT foot up in the runnings with the flat foot, so we can properly understand the complex deformity and start moving the outcomes forwards and improve the outcomes. So I believe that was my last slide. Yeah, we would absolutely welcome any questions, both myself and Mr. Malhotra. We're very excited to start the project, and we've got a lot of keen researchers in our unit that are going to help us with it. We'd be delighted to answer any questions about this study or group of studies.
Thank you very much for that very interesting description of your work. That's really brilliant. It's really good to see something that's going to have an effect in a very short order of time. Let's have a look at the questions we've got. I've got a raised hand, so I'm going to invite Diana to ask her question on stage. Diana.
Hello, can you hear me?
We can.
Yeah.
What are the chances of being left with ongoing discomfort or pain of any sort following surgery to straighten the big toes? And also, would AI help eliminate the possibility of any residual pain following an operation?
Do you want to answer that, Karen?
Yeah, sure. So part of the problem is, as I said sort of earlier, the goal of surgery is to improve balance and walking. Pain in CMT is multifactorial, and by that I mean there's more than one cause. So sometimes the pain is because of nerve damage. Sometimes the pain is because you've got extra pressure. Sometimes the pain is a combination. The question you ask is a very pertinent one, but it's also a very difficult one, because on its own, if you just treat the big toe without doing the rest of the foot, what you might often find is that it doesn't actually make any difference to the overall picture, because the big toe may not rub, but the balance won't be improved, etc. So it's rare that we actually end up having to intervene because of the big toe, and the opposite is also true with the pain and sensation. So a lot of patients with CMT can actually, well, they've never known a normal foot, so they can tolerate quite a large degree of deformity before they need intervention. The probability at the moment is difficult, but as a rule, when we don't understand things fully, although a lot of patients would be better, if you had to pick a number out of thin air, you'd almost sort of say 80%. But we don't accept 80%. And the whole purpose of the study is that we believe that 80% should be 95% success rates or 98% success rates. And that's really what this is about. I don't know if that fully answers your question, but there probably isn't a more complete answer.
Thank you. And Jeff is asking, again for you, Karan, excellent and valuable information. Should we be able to get a referral to your team from our CMT consultant or through a GP?
Either. So often well, probably most of the referrals we get are through established networks, through the consultants who manage CMT, just because they know about us and they have an idea about when to send people to us. The problem historically has been that as a specialist tertiary center, and because people come from far away, GPs have sometimes been a bit reluctant to send people far away. They'd rather send people to a hospital nearby. If you can, however, explain to your GP why you want to come and see us, there shouldn't be a problem, but we would take people from either source.
So we will see any patient with CMT from all around the country because we're a specialist centre for it. So there are certain GPs have a understanding that it's very difficult to refer into Stanmore, where we work, because we're a tertiary referral specialist centre. And certainly, if you refer some of the more simplistic things that can be treated locally, that we don't take them. But any patient with CMT, with a foot deformity from wherever, we'd be delighted to see them. Because we work very closely. We've got networks set up with the neurologists. We work with Professor Riley, and it's the sort of specialist surgery that should be done in specialist centres who have experience at doing it. It's not the sort of surgery that should be for an occasional foot and ankle surgeon, does one every few years, because it's a sort of thing that you need a good amount of experience with to get the best outcomes.
And I would just add to that, I do have quite a number of patients who sometimes come and say, oh, I was told there was nothing that could be done, and they come from somewhere far away. If you feel, and this is not self-promotion or anything like that at all, but if you feel that you are stagnating and you are not able to get forward, I think you absolutely should seek advice. Even if we end up doing nothing, there are a lot of our patients are actually managed non-operatively, but in a specialist MDT setting. So that's multidisciplinary team setting, where we have the appropriate expertise to make sure that we treat you in a way that you don't get worse quickly, even if you're not having surgery.
Okay, and after major foot reconstruction, what does rehabilitation involve, and how long would it typically take? So,
if you take the commonest type of CMT surgery that we do, either the sort of flexible, if it's flexible or fixed, the average rehabilitation will be, say you've got a flexible deformity, the patient will be in plaster, not putting any weight on it at all for 6 weeks, and then they'll go into a boot for about 3 weeks. But one of the things that we've touched on is the fact that you have to rebalance the foot. And a lot of the problems that we see is surgeries have been done elsewhere. We perhaps have slightly less experience. They will correct the bony deformity, but they don't rebalance the foot. So what happens is, over time, the deformity recurs. So because there's a tendon imbalance and things pull differently, you can correct it. It might look great for a short space of time, but then it will recur because the tendons are still pulling in the wrong direction. So we transfer tendons, so tendons that are pulling the foot inwards, that are overpowering the ones pulling the foot outwards. We transfer them so that they now balance the foot and they pull the foot outwards. And it takes some time in rehabilitation for people to relearn how to use the tendon, if you see what I mean. The tendon that was designed to pull your foot inwards has now been moved to pull the foot outwards. So there is rehabilitation involved. And although patients will see very quickly an improvement, so once they're 9 weeks down the line and they're back in their normal shoes, they're delighted, saying my foot feels flat, I feel much more balanced. But in terms of rehabilitation, they have to work hard with the physiotherapists to be able to regain the flexibility after the surgery, to regain the function of the tendons. And it may take up to 6 months or even a year to get your absolute full benefit from the surgery. So there is rehabilitation involved, but the outcome and the satisfaction is quite quick.
I've got a number of more questions coming through. If you're happy to ask them, we are going a little bit over time, but if you've got a...
I'm
very happy, very happy.
Thank you. Alison's asking if the balance issues she has with CMT are due to the loss of sensation in her feet or due to the poor alignment of the feet.
So it'll be a combination of both. So without going into too much detail, basically when your nerves aren't working, you lose something called proprioception. And proprioception is a fancy word for saying the signals which tell your brain where your foot is. And what you'll find is if you close your eyes and you feel more unsteady, it's because the signals aren't getting from your foot to your brain, so your brain actually has no idea where your foot is. So you're relying on your eyes to do some of that work and your ears to do some of that balance work. And that's part of it. If you then had at least a stable base, it's easier to compensate. But the problem is you also have weak muscles, so your weak muscles can't pull you. So even though you're trying to get the signal to say, oh, right, okay, I can just about work out where my foot is, your muscles have to work much harder to balance. And then if you have an uneven tripod, you are unstable inherently anyway. So it's a combination. And so exactly as Mr. Welk said, the rehabilitation takes a long time, because although we can make you balance the muscles a bit and get your foot flat to the floor so it's more stable, we can't improve the signal going to the brain and back. And for some people, it takes 9 months to a year to really completely get the maximum benefit, because they learn to walk in a different way. So it's all of them. It's all of them.
Okay, so a couple more. Once it becomes possible to create high fidelity 3D model of the patient's foot, can you envisage a time when this would enable augmented reality to help the surgeon during the operation and maybe spread best practice?
That's a really good question, and so certainly robotics and augmented reality in this type is pushing forward in the world of hip and knee replacement. So more and more hips and knees are being done using robots to help make the cuts absolutely perfect, and it hasn't quite translated down to the ankle replacements yet, but certainly in the future you might consider some augmented reality or robotics being able to help with the CMT foot. But I think at the moment we are a way away from that, because the sort of complexity of the rotations that you get will make robotic surgery quite difficult in the CMT foot. But I think that probably 15, 20 years down the line, it could potentially have a role, but we're not quite there yet.
Okay, and if we could end with this one. I was diagnosed with CMT at UCL 4 years ago. I live in Northern Ireland and my feet are flat but fixed. Could this new technology be used to correct the deformity in my feet? I'm very unsteady due to sensory loss.
So the one thing says that the new technology is still being, we still have a lot of work to go before it's ready for prime time, as it were. There's still a role in the meantime for assessment. So if you see someone who can assess the deformity, it may be that just because you have a flat foot deformity associated with CMT doesn't necessarily mean you have the severe deformity where it needs to be planned with a computer. But that can only be seen once someone's actually seen you. We still do operate on people even where we haven't quite worked out exactly how to maximize the deformity. But again, this work is about improving outcomes, improving results, and helping with the most complex places. But just having a flat foot in CMT does not necessarily mean that you're severe or complicated surgically, if that makes sense. So you don't necessarily have to have the technology, but either way, I think there should be something that can be done to help, whether it's operative or not.
And I think with the technology, even our plan is a huge amount of research that comes from it. But in the very short term, every patient, when we see a patient with a complex foot, we can use the actual, we can actually use the scanner to be able to help us plan the surgery. So if you have a complex deformity, we can put it all through the scanner to help us be able to plan the surgery. So we have less to do on intraoperatively during the operation, and you can plan exactly what you're going to do first. So I do think it will help with the management straight away of the patients. And I think that we're then going to translate that to be able to help the wider community treat these patients.
Thank you. Now I'm going to jump back. I've got a couple of questions for Debbie, which came through. I don't know, give people enough time to type their questions in. So a couple of questions here, Debbie, if I may. One is asking the research committee how much they're hoping to raise.
As much as possible is the easy answer. At the moment, we have enough in the funds to cover our plans for 2 years, and if we want to be able to fund research, it like the research that Matt and Karen have described this afternoon, then we really need to be thinking more about fundraising and having more funds available. It's as simple as that. The more we have, the more we can do.
And how much funding do you get from CMT? I imagine that's from CMTUK, I imagine, and from the NHS. I'm
imagining that's actually a question for Matt and Karen, because it makes, but from our perspective, we don't get any money from the NHS. All our money is derived from donations and fundraising from our members and any other source. So I did wonder whether that question was meant for Matt, although the timing of the question came in while I was still talking, so I'm not entirely sure what Jeffrey was asking.
Okay, well let's put it to Matt as well.
Yeah, so the NHS don't give us money to do this sort of research. They help us in terms of the infrastructure that we have here. So at Stanmore, we do an awful lot of research, and we are a tertiary referral centre, which means we see the complex patients from all around the country, but we're also very heavily involved in teaching and research. And the reason why we're involved in research is because we have an infrastructure around us. So we have a research unit with people who can help us to apply for grants, people that can help us to do statistics or complex statistics, people can help us recruit patients into trials. So if we start a trial and we need to recruit patients into it and follow them up, we've got an infrastructure around us. So that is, and those jobs are paid for by the NHS, the research jobs, but we don't strictly get given money for our research projects. That's why we have to apply for grants. So if I applied to the NHS for the money for this, it wouldn't be approved. But you can apply for grants through the NIHR, which is a national a national research committee, but the NHS itself doesn't give out money for this sort of thing.
Right, thank you. Well, I think we've come to the end of the questions. Debbie, do you want to add anything else as we wrap up?
No, I suppose just to say how thrilled we are that we've been able to help Matt and his team in this project.
And we look forward to reporting back to you as we find out more and more. And I'm sure each meeting will be able to deliver some really interesting work.
Yeah, brilliant.
That's brilliant. Thank you for that, and hopefully we can relay that to our members. And thank you. Well, thank the three of you for coming along this afternoon and sharing all that information. It's been really helpful.
Thank you. Thank you very much.